Welcome, everyone. We're going to just wait 1 or 2 minutes to see, because a lot of people are quickly joining now. And we have an exciting agenda. Hi, Farid. You can write questions always in the chat. And you can also, today we have, unfortunately, we have the news that Mendy Marsh won't be able to join. She has a family emergency, so she's going to be moving her presentation to our next call next month. So that gives us a little more time for Fiona to present from Trocaire on the situation in Tigray, and Jessica Goram Ariga, who has been supporting Genchi, the GBV coordinator in Ethiopia, is also joining us. They just had a briefing last week, which some of you may have joined, so she can also add information. And I think what will be nice is that we'll have some time for questions and answers after each of our presenters. So Mendy won't be here from Voice Amplify, but we will also, Sarah Martin will also have a little bit more time for questions and answers on the presentation of her paper that was, that she just wrote for the Helpdesk. And then the last group will be Kasi. And so yeah, in general, we'll have a little bit extra time. If we end early, I'm sure no one will be disappointed to be able to get out of a call a little early. So we'll see how it goes. So I think we can, well, no, the number is still jumping very quickly. It's like in 1 minute jumped up to 56. So let's see if the number has stabilized. Great, I see people are introducing themselves in the chat, which is great. Please feel free to put your name and organization in the chat. It gives us a good idea of where people are listening from, which is always nice to see. And also, if you want to put in what your post is, that's nice to know if we have coordinators or if we have global people or different organizations. It's always nice to see that as well. So our number is still climbing. I think we can go ahead and start. We have 59 now. We never know how many to expect. Just to remind everyone that we do record this call, and because of the request, we are now posting the call on our website. So I know there were a number of people who wanted to attend today but couldn't because of other meetings. So we will be happy to share. And I think we've been sharing it on our website or in our MailChimp sometimes. So you do have access, and just be aware of that too, so that if there's something sensitive that you'd like to ask, then you can write to us by email and we can respond by email, just so you know that it is being recorded. But I hope that won't prevent you from engaging in conversation. And then please do any questions if you want to put them in the chat so you don't forget them while people are speaking. That would be great. So I'm going to start with Fiona. You can already see her PowerPoint here. And we have had in the past a presentation by the coordinator, by Genchi. And like I said, there was a briefing last week on Ethiopia. And also, I hope some of you saw the statement that our policy advocacy reference group helped us develop, that we sent out last week, which was also including recommendations for what's needed in the Tigray region. And I think you're going to hear more about challenges and needs today. And then Call to Action also sent out a statement. So, and I think the principals actually just had a meeting. So there's a lot going on around the region, and I'm sure the briefing from Fiona, who is one of our core members, and she just returned last week and she's still in quarantine. So we appreciate that she's taking this time with us. So I will hand it over to you, Fiona.
Great, thank you very much, Jennifer. And it's great to see so many people on the call. So yes, I'm just going to give a very quick input on a recent deployment, as Jennifer was saying, for the Tigray response. So my colleague Etinesh Malati was unfortunately not able to join today, but the deployment was together with Etinesh, who is our Protection Programme Officer with CST in Ethiopia. So I'm with Trocaire, and CAFOD, SCIAF and Trocaire work together in partnership in Ethiopia. It's the only country in the world where we do that, and it's called CST together. Just because it probably doesn't have name recognition, just so that people know the organization that we're talking about. And then also Gente is currently in Tigray, and so isn't able to join the call today, but we've coordinated on some of the messages and some of the key points that we're sharing. So if we could move to the next slide, Shiva. So maybe just to start with, the main focus of the support visit was around our GBV and emergencies program support as part of the Tigray response. And so our key partners there would be ADCS Adograt, Daughters of Charity, and ADCS Mekelle. So ADCS are a humanitarian agency delivering multi-sectoral services with 350 staff. Daughters of Charity, again, a humanitarian agency, 160 staff. Both organisations are heavily engaged in health and social services, but before the crisis, they were not engaged in GBV specialised services, although they were engaged in women's empowerment programming with CST, and they have been responding to survivors since the onset of the crisis, particularly in the communities that they serve. Key strengths really of our partners are, you know, the local knowledge, reach into communities, networks of health facilities, women's centres, and Wareda and Kabele level presence, particularly a high levels of acceptance within communities. We're working in close coordination with the GBV AoR, particularly at Mekelle level, but also national level, and the response services that are available within Mekelle town, and a key kind of a key resource and focus there is the Women's Association of Tigray, of course, and also OneStop Centres in Mekelle, so the one that's functioning in Mekelle, and the OneStop Centres that are currently in the process of being established in the other main government hospitals in main towns. So that would be Adograt General Hospital, Ida Referral Hospital, Axum Hospital, and Maychew Hospital. So making sure that, you know, the response services that are present and available in the areas where we're working, that we're linked closely with them. So our own focus is primarily thus far East Tigray, particularly Irab, Wareda and Gulamakada. That's been an initial focus of the response, particularly health responses to GBV case management. We're expanding at the moment, particularly over the last couple of weeks, to 9 additional Waredas, 5 in the east, 4 in the south, and also IDP centres. The main focus of the programme is around health responses to GBV, GBV case management, which was a core focus of my visit, then dignity kits, referral systems, community-based psychosocial support, women and girls safe spaces. These last two very much in the setup phase at the moment, with kind of additional funding that we're working on at the minute. So maybe if we could move to the next slide, Shiva. So capacity strengthening, in addition to that programme support, was an important focus of the visit, particularly facilitating a GBV case management training based on the interagency GBV case management guidelines with Etinesh. 14 female staff were involved in that, predominantly with a health or a social work background, from ADCS, Daughters of Charity, and also from the OneStop Centres. So 5 key staff who are working as caseworkers within those centres. And those centres are being supported by UNICEF and UNFPA. The focus of the support also included a focus on staff support and supervision, putting those structures in place, staff care and facilitation skills, acknowledging that these staff are supporting other staff within their organisations and within their areas. In addition, we included a focus on safe information management, particularly as that's a real gap at the moment, looking at safety and ethics, contextualisation and translation of the core case management forms into Tigrinya. In addition, we facilitated staff care and PFA orientation sessions for general sectoral staff, and that was 2 one-day sessions for staff working across sectors. So thinking of kind of your level 1 basic supports, making sure that staff have access and understand kind of how to provide basic psychosocial first aid and referral within their organisations and to other organisations. And then a key focus of the visit, but also of the follow-up support, is around resource development. So developing referral pathways, information management, summary notes based on the minimum standards, and also short guidance notes into Grinya on GBV case management, psychosocial first aid, information cards, and translation of some of those resources is in process at the moment. If we could move to the next slide. Shiva, please. Thank you very much. So a key thing that I thought it might be helpful, or we thought it might be helpful to flag within this group, is some of the challenges and concerns that we're seeing and experiencing, both in terms of experiences on the ground during the visit, but then also from discussions with the GBV AoR in country. And, you know, this almost doesn't need to be stated. The security context is a significant challenge. Access is a significant challenge. One aspect that we're struggling with a bit, and this was also mentioned in the briefing on Friday, is that there are very few international agencies engaging in or supporting GBV service provision on the ground. So IRC in Shire would be a key one. But in terms of other INGOs, it's a bit of a difficulty at the moment in terms of actual service provision. Local partners are supporting survivors in very difficult circumstances, and that's, you know, often happening without GBV specialist support. Service providers that are working in one-stop centres in main towns highlighted real significant gaps in terms of capacity, knowledge, you know, access to training, and availability of supplies and you know, some of the basic structures to provide services. And yes, linked to this last point around kind of like basic structures, minimum standards for service provision aren't in place, and you know, that really an interagency effort is needed there, particularly around things like safe information management. And we've kind of all seen some examples of that and some of the difficulties there. So if we could move to the next slide, just some of the ideas, and I think, you know, it would be really good to open up the conversation and get other perspectives and ideas around this as well. One big thing that, you know, I think we would all acknowledge is, you know, the real need for greater investment in coordination capacity, particularly prioritizing coordinating service provision. So developing referral pathways, making sure that we have SOPs that are in line with minimum standards, safe information management, and, you know, prioritizing health and psychosocial services, particularly in this very acute phase that we're in at the moment. The interim GBV AoR coordinator at Micah level, so that role is going to be in place from the middle of May. And something that's really critical is ensuring longer term funding for this position. At the moment, 3 to 6 months is committed, and I think just acknowledging the situation that we're in and the need for longer term support for that position is critical. Establishing a service provision task team of the AoR at Micah level, we feel could be helpful, particularly just to bring together those who are providing services, and make progress on some of the key gaps that are there. Developing an interagency or a few interagency communication products or guidance notes, particularly on issues of concern like information sharing, safe information management, and encouraging other international GBV specialised agencies that have a presence in Tigray but are maybe supporting other aspects of the response, to maybe perhaps focus a little bit more on service provision, and seeing how best to collaborate and collectively support teams and partners to provide services. So I'll leave it there, and really keen to have a discussion and see what might be most helpful in terms of next steps and taking things forward, and very open to any questions. Thank you.
Jessica, I just want to ask if you want to add anything before we open up for discussion.
Hi, Jennifer. Thanks. And thanks, Fiona. I think you hit on a lot of, or most of the main points. And I just wanted to reiterate, and I think you mentioned this, but the real need for agencies who specialize in case management, because a lot of the concerns that Fiona, you mentioned, really do center around the case management. And I think because in Ethiopia, that function was a function of the government prior to this crisis, and in lots of the development areas in Ethiopia, there's a huge gap. So, I mean, it's very disjointed on the ground, as Fiona mentioned. And even when the government was sort of taking or had the lead on case management, they didn't necessarily have the capacity, the technical capacity, or the resources to do that. So we're sort of starting, I would think, even kind of at a below the lowest level in some ways. So can't stress that enough. And then just from the coordination perspective, Ethiopia is the only coordination mechanism, I think, globally in the world that they have child protection and gender-based violence together. So they have two distinct coordinators or separate coordinators, but they do partner at national level together. And I think that works at national level. And then Fiona, some of the issues that you mentioned, or ideas for improvement around coordination, I think we're going to have to think about the possibility at subnational level of perhaps separating those, just because then we get into some very distinct roles and responsibilities. And I have to say, you're exactly right again, Fiona, we don't have a coordinator there. So we're really dependent on UNICEF's coordinator, and we're grateful to the work that he's doing on both behalf of CP and GBV. And he's kind of keeping it together for us. And so can't say enough about the work that he is doing there, but also recognizing that he's basically doing two full-time jobs on coordination. And then of course, he's also got his child protection work portfolio as well. So just to reinforce those 2 points, but I really agree, Fiona, with everything you've said. So over.
So thank you. I'm going to open it up now if there's questions or comments. And just to let you know, Fiona, we have the coordinator who's been sitting in Bangladesh trying to deploy and is stuck in Bangladesh because the borders are closed due to COVID. Chacha, he's online. And then we also have Monica Vega, who's going to be going and deployed for the psychosocial MHPSS work as Serge from UNFPA. So just to let you know, you also have some people online that I'm sure would love to talk to you afterwards for more information before their deployments. So any questions? And I don't know if any questions have been written into the chat. I've seen mostly people putting their names and organizations here, but yeah, we have 76 online. So I think it's fine if you want to just ask a question. Okay, we have 3 participants with their hands raised. And why don't I see who raised their hand? Oh, okay, I'm not seeing oh, here we go. So yeah, so I just mentioned Monica, who's going to be deployed there. So go ahead, Monica, do you want to ask your question?
Yes, thank you, Jennifer. And hi, Fiona. And maybe this is also like a way to introduce myself, and that like I'll have a like parallel call with you. But I will be very interested, since you've been like having the opportunity to be training people on case management and what Jennifer was saying, in terms of like the needs for case management. And on the other hand, as highlighting the importance of psychosocial interventions and giving the challenges you've been identifying, what would you think that would be for you? What do you have in mind when you think about psychosocial interventions at this point of the emergency and the capacities, etc.? Like this is.
Thanks for that, Monica. And yes, it would be lovely to connect and talk ahead of your deployment as well. So in terms of psychosocial interventions, I would generally be thinking in terms of those that are, as they're kind of set out and organised within the minimum standards. So at level 2, a core one would be women and girls safe spaces. And in terms of the psychosocial content and the psychosocial sessions that are offered through those spaces. So particularly promoting the 5 essential elements, looking at safety, calming, connectedness, self-efficacy and community efficacy and hope. At level 3, the core one from my perspective would be GBV case management, and particularly the GBV case management itself as a psychosocial level 3 response, but also the provision of psychosocial interventions within the context of GBV case management. So when you're at the implementation phase, and providing focused one-to-one support within GBV case management, and then also focused support, so other level 3 interventions that are not necessarily within the context of GBV case management, so psychosocial support with other issues or with other populations, but also drawing on kind of focused non-specialized supports. And yeah, I do think that that's kind of the real focus of where things need to be in terms of what the needs are for the majority of the population. There are some specialized supports available, but I think for specialized support, yeah, a kind of a more detailed conversation is probably needed there. I think, yeah, our core focus is at level 2 and level 3 in terms of the MHPSS interventions, but happy to discuss further as well.
Okay, thank you, Fiona. No, it's great, like to start to have like an idea, and yes, I'll email you maybe, and we can have like a separate call for this. But thank you. That's also giving me a bit of a picture of it.
Great.
So we have a lot of MHPSS related questions. We have Carmen Valle here, who's from the MHPSS reference group, and she works for IFRC. So Carmen, over to you.
Thank you so much, and thank you, Fiona, for that presentation, and welcome everybody. I've been wanting to join your call since I joined this role at the beginning of the year, and it's been tricky, so I'm really happy to finally be joining you. Maybe I'll just turn on my video for a second so you can see my face. I just wanted to very quickly update, because I think the MHPSS technical, well, MHPSS reference group has been having the same struggles that Fiona has very clearly highlighted. But we have some recent developments that there is now a technical working group for Tigray being established. Unfortunately, the person with IOM who initially established with the Ministry of Health had to leave the country, but someone else is coming. So there's right now colleagues from ACF, IOM, and the Ministry of Health establishing this technical working group. So I'm going to copy my email from the reference group in the chat. And if anybody has any needs to contact the technical working group in country, please feel free to send me an email. And maybe a final word to really commend and thank the GBV AoR responsibility and all of you for highlighting so much the need for psychosocial services, because this advocacy effort is having a big impact, and we're really happy to try to support as much as possible. So from the reference group, please reach out anytime, and we'll continue to try to support as much as possible. Thank you so much.
Thank you, Carmen. And Kate Ruby, who is works on the interagency GBV IMS and does a lot of case management training herself. So Kate, over to you.
Thank you. Hi, everybody. Thanks, Jennifer, for the intro. As Jen said, I am the interagency coordinator for the GBV IMS interagency group at the global level. So for those of you who are less familiar, that's a group made up of UNFPA, UNICEF, UNHCR, IRC, and IMC. Fiona, thanks so much for the presentation. You mentioned that you've been doing some capacity building around safe information management in the context of case management. And I wondered whether with your partners who are providing those services directly, whether you had considered GBV IMS Plus as safe information management system for case management.
Thank you. I'm gonna probably ask Jessica to come in on this as well, in terms of, I know there are ongoing conversations with yourselves at the global level around the GBV IMS, and Jenche would and Jessica would be much more up to speed than I am. My understanding is that the GBV IMS is not intended to be rolled out in Ethiopia. For GBV IMS Plus, our concern would be, I suppose paper-based systems feel more possible within this context, in terms of access to technology, access to devices, but also the fact that there isn't any internet access. So cloud-based systems and kind of secure storage is also impacted by that. So you, at the moment, need permission to have internet as an organization since the blackout, and that has been some organizations have access to that, some don't, and it's quite limited in terms of the strength of connections and the numbers of hours a day and things like that. So it's quite constrained. But I think we're having ongoing conversations about the safest and most secure way to keep information, but also the impact of the security environment on what we collect and what we ask is significant as well. And so we are definitely operating with an abundance of caution in the environment at the moment. Is that helpful? And yes, very keen to talk further.
Yeah, I mean, let's maybe chat offline together with Jessica. I know that in the past when we've talked about Ethiopia more broadly in terms of GBV IMS or GBV IMS Plus, I think one of the things that had come out of those discussions was the fact that in the non-refugee response, that there, as you'd made reference to earlier, that or Jessica had mentioned, that there was a lack of NGO service providers providing services directly, and when it comes to governments and rollout of an IMS, that gets a little bit more complicated. But just in the context of a scale up of NGOs providing services directly, it might be something that's worth kind of picking up again. And we have managed to roll out GBV IMS Plus in contexts that have relatively low internet connectivity. So all that to say, I'd be happy to discuss it further, or just keep that conversation going. And thanks very much.
Thank you, Kate. And the last hand that I see raised is from Chacha, who I mentioned earlier, is the coordinator who's been trying to get there from Bangladesh, but one of the victims of the pandemic, in the sense that he hasn't been able to get out of Bangladesh since the borders closed. But over to you, Chacha.
Colleagues, good afternoon. For those others who are in the morning, good morning. Just quickly, that's the face waving. I have actually finally been able to leave Cox's Bazar. I'm now in Tanzania. I should be on ground at least latest mid-May, latest 20th May. All factors remain constant. Thank you, Fiona, for the presentation. Basically, quite a lot of insights into what to expect on the ground, and essentially quite true of a situation where there is a lot of more or less groundbreaking work to be done, and I'm happy that there is already a lot of work that has already been done in terms of setting the course for strengthening and improving whatever is already on the ground. I think I didn't want to say so much except just to acknowledge the fact that this presentation is really appreciated. The information provided will provide a lot of clarity in terms of how we move in, what to expect and what to start working with, and at least realizing that we will not be alone. There is already ground set, there is already colleagues and partners working there. So looking forward to great collaboration as well with the teams that we shall have on the ground. Otherwise, thank you. These were my comments. And thank you, Jennifer, for putting together this one as well.
Great, thank you,
Over,
Joshua.
Jennifer, to you.
That is very good news that you're in Tanzania. So excellent. And it's also great that you're going with so much experience. You know, I met you in Nigeria, and then I know you've been in Sudan, and you've been in Cox's Bazar. So I know you're going with a lot of experience, which sounds like what we really need there. And it looks like you will have a lot of challenges waiting for you. I did want to, we are going to move on shortly, but I recognize that, you know, Sarah Mosley is online from IRC, and we also have Micah on from IMC. So I didn't know if either one of you wanted to make any comment following before we end the part of the discussion on Tigray. Oh, there's another hand raised, I'm being told. Oh, Ashley, okay. Can we?
I can actually wait from Micah and Sarah, actually, if you want. I'll pause.
Say that again?
I'm happy to wait if Micah and Sarah want to
Okay.
contribute.
So Micah or Sarah, would you like to say something?
I've been waiting for Sarah to go first. This is Micah, but I can start if you want. So IMC has had mobile health and nutrition teams in Tigray for a while, and we should be starting pretty imminently to introduce GBV services, both mobile and static, including case management in different locations, West and Northwest Tigray. I was planning to deploy, well, I was planning last week, we'll see. It will be me or another TA is going to help start up the intervention, and we're working on finalizing recruitment for a program manager who will also deploy very soon. So I don't really have anything to add right now, except that our team is obviously coordinating in country, and we hope to be initiating services really, really soon. Thanks.
That's also very good news, Micah. Thank you for that good news. And Sarah Mosley.
Yeah, I'll keep mine brief as well, but just to say that we're also operational and are looking to ramp up women and girls safe spaces in partnership with some women's organizations that we've had partnerships with over the long term, as well as some additional organizations that we've identified. We're coordinating for the most part internally, so that therefore most of the surge support is actually being pulled from other parts of the WP team within Ethiopia, in addition to some support from our emergency response team, but I believe that is for the most part now still mostly remote support, given some of the travel restrictions that we're facing as an organization. And then, yeah, so I think to the best of my knowledge, we're not offering medical care in those areas, but I can double check that. So it's largely women and girl safe spaces with case management and psychosocial support, as well as activities and or services focused for adolescent girls. But I can definitely double check on the medical care, but I don't believe that's happening.
Thank you. And just to say, we do want to have a core member call with Fiona soon, so that we can also sort of look at, you know, how we can be scaling up in some of these different areas that have been discussed. Ashley, do you want to ask a question or make a comment?
A question would be great. I actually have two. First, with the one-stop centers. So my understanding is there's one in Mekelle, but there's discussion of expanding these. And I'm kind of curious as to, you know, your assessment of, like you said, the status of these, and if they're going to actually be able to serve significant portions of the women and girls in need. And then second, kind of tied to that, and Micah mentioned the mobile teams, I was curious with kind of like rural extension efforts, if we see most of our kind of like approaches being static, or if we think scaling up mobile teams, kind of just more of a longer term strategy, if that's going to be feasible. Thank you all. Over.
Hi, I can maybe answer the question about one-stop centers, well, to the best of my ability. This is actually an initiative, or was promoted by the ministry, actually. The government was really pushing one-stop centers in areas that we're not necessarily sure would be best place to to host a one-stop center, particularly since some of those concerns that Fiona had mentioned about meeting global guidelines of care. So yes, Ashley, I'm glad that you brought that up. So it is something that's being sort of, I don't want to say pushed, but the government is really keen. I think they see it as a model that works, and it is one that they have in different regions throughout Ethiopia. And again, we're hesitant just for the reasons, again, that Fiona. So I'm not sure how that's going to be reconciled, to be honest. And right now, we don't even have all the resources we need for the existing one-stop center. And there are a couple other one-stop centers in the greater Tigray region in the other provinces. So it's not a good answer, but that's there. And then also MSF is quite active. I don't know if we have anyone from MSF on the line, but we've also been having conversations with our MSF colleagues, because they usually provide a good sort of, wholesome, holistic care in their medical centers. And what we're really keen also is to, and they often, as you know, in the Tigray region as well, they're working in some pretty remote areas. They were there previously and are still now working in those areas. And what's really good, we think, about MSF as well, in their comprehensive package, they also provide MHPSS support. And so we spoke to some of our MSF colleagues. They don't yet have that up and running in all of their facilities, but they recognize it as a gap that we have put forward from the GBV side. And again, I think Fiona mentioned some of those reasons. So we're hoping that they'll scale up during MSF scale up as well. They'll recognize the need for MHPSS services so that we can provide a bit more holistic care in some of those remote locations. And maybe that will provide an incentive, or maybe be an incentive for the government not to sort of, maybe carelessly is not the right word, but to just push these, the rollout of these one-stop centers. Because I'm sure many of you on the call know that they're complex, right? And you can't just set them up when you don't have the resources, the money, financial resources, but also human resources. So yes, that's the short answer to that, Ashley. Over.
The short answer. Good
Yeah,
thing we were asking for
I
the
could go on.
Okay. Fiona, did you want to add anything to Ashley's question? I didn't actually introduce Ashley, but Ashley works with BHA, which was formerly known as OFTA.
Sure, I will. And maybe just very briefly on the one-stop center staff who were involved in the training. So they came from the other areas of Tigray, as well as the Mekelle one-stop center. So there's one kind of functional in Mekelle, and then there's ones in the process. So staff have been recruited, they're responding to survivors, but the actual kind of capacity strengthening and support is still needed. And so staff participated in the training from Ida Referral Hospital, which is within Mekelle, Axum Hospital, Adigrat General Hospital, and Meichu General Hospital. And so those are all main towns. I think, yeah, I'll just leave it at that actually for the one-stop centres. And then for your question around mobile teams, yes, so mobile responses is something we are developing at the moment, particularly from static health facilities. So just the impact in terms of health facility functioning has been huge. And I'm sure everyone is well aware of that in terms of the damage to health facilities, supplies, the fact that many staff left, and many health facilities aren't functioning at all. So the health facilities that we're supporting kind of to refunctionalize, and then also having mobile teams going from those health facilities to other areas where maybe the existing health posts, like the vast majority of the health posts, aren't functional at all. And so, yeah, mobile teams providing health responses and GBV case management will be something that we will hopefully have up and running shortly. At the moment, we're kind of in the recruitment setup phase for that element of it. But I would agree with you in terms of longer term kind of addressing some of the challenges, and particularly some of the access challenges that we have. I think mobile services do have to be part of the strategy, and and those are often kind of co-located with other services that women and girls are accessing. So yeah, I'll leave it at that for the moment. Conscious of time.
Thank you, and I'm sure we would love to keep discussing this, and hopefully there will be other opportunities. It's been nice to have a little extra time to do this. So I do want to move now on to Sarah Martin, because we don't want to cut anyone else's time. But if at the end we see there's any extra time, we can come back to this. I don't think Sarah Martin requires much of an introduction, because hopefully all of you know her from being the moderator of the Community of Practice. And if you're not familiar with the Community of Practice, by all means, go to our website and sign up. And I guess you could say, Sarah, I think she does more than double hatting. She wears many hats because she also does all kinds of interesting consultancies. And today she's presenting on a paper that she wrote for the GBV AoR Helpdesk. So apart from the COP, she also supports the Helpdesk. So over to you, Sarah Martin.
Thank you, Jennifer. Thanks for that great introduction. And again, I always take the opportunity to plug the COP. Please send us a message at the gbvcop@gmail.com if you want to join us. I was asked by the Helpdesk. I'm on the roster for the Helpdesk as one of the many different specialists that they have. And I was presented with this very interesting inquiry and asked to put together a presentation for it. And it was really interesting for me to delve into this because like many of you probably, my background originally was in reproductive health, and I came to GBV through working in reproductive health. And I also used to work for MSF, and we worked and looked a lot at the issue of termination of pregnancy and abortion as well, which is something that we don't talk about very often right now in the GBV circles. So it was interesting to be able to plug into this and to look at this topic about how do we support GBV survivors who find themselves pregnant due to rape. Thanks, Shiva. The next one. So the query came in from the field, and they were struggling a bit with a number of different issues around this. And they were finding that they had a number of survivors, predominantly young women, coming forward to give birth. And at that point, they had not interacted with the health system or the GBV system at all until they were almost due to give birth. And then they were also not all of them were prepared to take care of their children. So they were struggling a bit with what to do. So what I found in there is, while there is so much evidence out there right now, particularly on sexual violence in conflict settings, there's really not as much peer-reviewed research on pregnancies and childbirth due to rape. And there's very little in humanitarian emergencies, and not so much written as well on supporting survivors. So I went into what we call the gray literature, looking at a lot of reports and guidance and internal guidance that's been developed by NGOs, by the UN, and by a lot of abortion rights organizations as well. And as well, some of the information was really captured through newspaper reporting or media documentation. So, it was, we had to do a broad net to find this information. The next one, please. So what is the scope of the problem? We were attempting to look and see what is the likelihood actually that rape will result in pregnancy. There's a lot of myths out there, and we've heard it from particularly anti-choice politicians, like in the US where I'm from, that, if you're raped, your body shuts down pregnancy. But those of us who work in this field, we know that that's not the case. So from what one of the pieces of evidence we found was that there's an estimated 4 to 10% likelihood that a rape might result in pregnancy. Although this number was, contested, and it was hard to find a lot of hard data on that. But what we do know is that medical service providers operating in areas where we know that there's high rates of sexual violence are seeing a demand for abortion for unintended pregnancies. not necessarily due to rape, but also we know that there's a lot of life-threatening effects of unsafe abortion in humanitarian settings. And I myself worked in the Rohingya crisis a few years ago, and we saw some, horrific incidences of women attempting to perform abortions upon themselves. So often the medical system gets involved when it's too far along, and they have to kind of deal with the aftermath for the survivor. So this was an opportunity kind of to look at what could we be doing to prepare ourselves for this. And like many of the places we know, adolescent girls and women with disabilities may be more at risk of dealing with this as well because of their lack of access to health services. Next slide, please. Oh, I think someone has their mute on. All right, so I just kind of focused again on a few of the key settings where we know that there are some numbers and there's data out there about pregnancy due to rape. Rwanda has been studied, and we, with the numbers that we kind of have, approximately 350,000 women were raped during the genocide and 20,000 children born, but that doesn't tell us how many women may have lost the pregnancy, or may have aborted, or may have died. Yugoslavia, the former conflict in Yugoslavia, was probably one of the first places where we really started to talk and see about this at an international level. Northern Uganda, there was significant stigma from the girls who came out of the Lord's Resistance Army abductions, who often were pregnant or had children, and it was very, very difficult for them to reintegrate back into their communities. So we learned about it from there. Probably the bulk of the information that we have comes from, the Pansy Hospital and all of the amazing work that they've been doing in the Congo, and, working with pregnant rape survivors and supporting them and figuring out ways to try to address their needs. More and more, MSF had released a lot of information about women pregnant due to rape in the recent refugee movement into Bangladesh from Myanmar. And then again, in Iraq and Syria, looking at what the Yazidi women have gone through has also given us information and helped us to understand what's going on. Next slide, please. So the impact is high, both on the survivor herself, but also on any child that might be born of rape. And there has been, research out there on children born of rape that was quite I would say, particularly popular topic for a couple of years ago. So there are a number of kind of literature reviews around focusing on what happens to the children afterwards. But not so much about what is the actual experience on the survivor herself going through that. So we do know, and again, a lot of this data comes from the West, from the United States or Europe, that rape-related pregnancies may have a higher incidence of miscarriage, that, as I mentioned before, the attempts at self-abortion or receiving an unsafe abortion has life-threatening consequences. And what we do know from like the Alan Guttmacher Institute, who looks at the issue of abortion around the world, at least 23,000 women die from unsafe abortion every year. And many, 7 million women are admitted to hospitals due to unsafe abortion. So, and of course, we don't know how many don't survive that. So because it is such a traumatic event for a survivor, many women are willing to go to extreme lengths in order to end an unwanted pregnancy due to rape. But we also know that women who are pregnant due to rape can have additional health problems due to infections they may have received from the rape, or an injury, particularly any pelvic injuries or injuries to their reproductive organs. And so that could make delivery of the child quite threatening for their health. And then the mental health aspects are, survivors often experience anxiety or depression, and we have seen, of course, suicide as well. And then on top of that, you have the societal and stigmatic exclusion for rape survivors that impact both the woman herself, but also her child, which may lead her to abandon or to flee from her community in order to survive. Next, please. All right, so I tried to look at it from our ecological model. Next, please. So I broke it down into 4 different areas. The first one is one that is often kind of under performed from my experience in the field, is really doing a context analysis. What in that culture are the different ways that women who have found themselves with unwanted pregnancy treated? What are their options? How do they perceive this? How does the community perceive this? What support is available in the community for it? And going beyond just the legal frameworks, you can sometimes find the legal information about termination of pregnancy or how rape survivors are treated. You know, what are their rights? Or what are the obligations of service providers, particularly around the topic of mandatory reporting. But there's often not as much information out there, or it's not gathered by aid workers looking at the cultural understandings within the community. So, and going beyond just looking at rape, just understanding what a person who's unmarried, what their experience might be around being pregnant and unmarried, what the community's thoughts and attitudes are around abortion, around women's reproductive health in general. What is their perceptions around single motherhood, and what are their perceptions around sexual violence? So having, in order to create a thorough and compassionate response, we should have in place already a protocol to understand how to respond and to react if a survivor comes forward who's pregnant. Now, of course, many of us don't have that in place, so that shouldn't delay from providing care. But hopefully this, this note can help people think through what they need to have in place in order to provide support. And then lastly, again, looking at what happens if the survivor is not able to terminate her pregnancy, does not wish to terminate her pregnancy, or is not able to care for her child. Perhaps she might die in childbirth, or she might decide she's not ready to be a mother. What will we then do with the newborn? And that was that's a big struggle in many places with abandoned children as well. Next one, please. So the second part is making sure that we have survivor-led approach and a case management led approach to address her many different needs. Because the survivor herself, you know, is an individual, and she has specific needs due to her culture, context, family, and just her own needs as well. We can't make bulk assumptions about whether or not they're willing to have the child, if they are willing to undergo an abortion, if they want to, what their plans and their hopes are for the future. So having you know, a sensitive survivor-led approach is the best way forward. And I know I'm preaching to the choir here too. But there's, we identified a couple of areas that are really important to have in place. So offering pregnancy testing with counseling involved. So that is a safe place for someone who may fear that they're pregnant due to rape, that they can come forward and that they can, in a supportive environment, assess their different options on what they want to do. You know, we know particularly for adolescent girls, there's not always a lot of information, good information for them about the different services and reproductive health things that are their rights. Often information and education campaigns around emergency contraception are not in place. And community outreach around this is very, very important, because the knowledge that there is emergency contraception, of course, is a draw to be able to bring someone who suspects they might be pregnant due to rape, to be able to come forward and to address it early in the pregnancy, so as not to find themselves later with less options and choices. Identifying and understanding where there might be safe abortion services available is really important. We know that in many of the settings, MSF offers what they call termination of pregnancy services. IPASS is operating, that's an American abortion rights organization. They're actually operating clinics in Bangladesh. Marie Stopes International is in many, many different places. International Planned Parenthood also has networks around the world. So it's important to be aware of that and to be able, you know, maybe if the agency's unable to do it themselves, but to offer a safe referral as well to a pregnant survivor. And if the survivor does opt for abortion, to be able to provide post-abortion care for them, because often the abortion services are very far away, and it's hard for someone to, you know, stay out there for a long time. So making sure that there's good post-abortion care, even for women who have chosen to do it themselves. Often women may go to pharmacies to buy medications, or they may resort to, midwives or traditional birth attendants to get it done. So making sure that there's good, safe post-abortion care available. And also mental health counseling, that's where they can come forward and they can talk about their feelings, because, with the hormones that are involved in being pregnant as well can really inflame and hurt self. The next one. So for many rape survivors, their physical and mental health might be placed in jeopardy by having to undergo childbirth from an unwanted pregnancy. The research shows that women with PTSD are at greater risk of adverse childbirth outcome. And, women who have been raped are at risk of PTSD. And particularly young girls and adolescents whose bodies are not yet mature, or women, again, who've had a serious pelvic injury, delivery can be extremely difficult for them and they may not survive it. But other really important things to think about while offering for the survivor who has to deliver or who may wish to deliver is maybe making sure that you have shelter in place. Many of them do not feel safe at home. They may need to live for several months away from their home community to deliver. And one example that was shared was that IMC in Nepal has mother and child transition homes, and Pansy also has places like that. Often there are ad hoc shelters in hospitals, around clinics, in camps where women and their children can stay. But often these women already have children from previous relationships and may also need childcare. They may need food. They may not have someone who can come with them to support them and to help them. So thinking through all of the needs that they may have and to provide them shelter is an important thing to have in place. Postpartum counseling is very important, because postpartum depression could be an issue for rape survivors. Most women, there's not high evidence that a rape survivor would necessarily have postpartum depression, but there is always that risk. So making sure that you have a ability to follow up with them and to support them afterwards is very important. And then again, if the survivor has decided that they do not wish to raise the child, what are the different options in place to provide placement of this child? So many of the countries we work in do not have good adoption procedures, or it's very difficult, and don't always necessarily have fostering situations in place, or that may be extremely, an extremely local and non-formal fostering system where the child is taken in by the community and then the service provider doesn't know what happens to the child later. But there's a lot of limitations in place, so it needs to be thought through ahead of time, like how will you support a child perhaps that's been abandoned after pregnancy. Okay, the next one. So finally, what about the survivor who decides to keep the child and has gone forward with it? So we know, again, from DRC and the Pansy Hospital, that they found 60% of their survivors were unable to return to their home communities. It can be very, very difficult because of what we spoke about in the context analysis, the community social norms around unwed motherhood or rape, or a child that's born of rape. So, but despite that, there are countries that have targeted programs for rape survivors, or even reparations programs for sexual violence, and to various degrees of success. But one kind of examined issue is the fact that a child that's born of rape also should be registered at birth, because unregistered children become at much higher risk of sexual exploitation, of trafficking, of forced recruitment. And that's the first step towards being able to provide protection for this child. And there's often not anything in place for that. Although I do mention in the paper, there was an interesting program in Egypt that was working with that to provide birth registration for children born of rape. So there's some lessons we can learn there. Making sure that the survivor or the child has the financial and other emotional support that they may need to raise the child. in Myanmar in the past, before what's currently happening, but there was a program that had been developed to assist disabled women and their caregivers who had gotten pregnant by rape. So because we know disabled women and girls are often extremely vulnerable to that, there was a program there to provide some care and support for them. But then there's also a very well documented and interesting, the Pigs for Peace microcredit program in the Congo that has targeted survivors as well. So economic support, livelihood support, but also just emotional and community support for these survivors is very important. Through the Yazidi women, there's been some interesting learning about how to reintegrate the survivor with the family and the community. Organizations and the women worked with the leaders of the Yazidi community to accept the women who had been sexual slaves from ISIS back into the community. Unfortunately, though, they often are accepted back, but not their children because of their cultural beliefs of the father of the child passing on the membership of the Yazidi community to it. So there's ongoing discussions and negotiations and work with that. And I think there's some interesting learning that can come out of that as well. And then finally, something we don't always talk about so much, but access to justice. A lot of the survivors, we need to ensure that they still have access to justice. And I did find examples of reparations programs for sexual violence survivors in Congo, Brazzaville, in the Eastern DRC, Croatia, Bosnia, Kosovo, and in Colombia as well. Now, they're mixed, of course. Not all of the survivors who need it get the care that they need, but there are some precedents that we could look at to ensure. The next one. So this leads me as well to an important thing, is the importance of coordination across the different sectors to be able to address the needs of these survivors. So obviously working with the health cluster or the reproductive health working group within the response is really important to ensure access to health services. WHO and UNFPA and a lot of the organizations have put out good training materials and materials on how to sensitize the healthcare staff around this topic. But often that gets left out. So having joint coordination programs, and I'd say that the whole of Syria GBV response worked very closely with the reproductive health working group as well to kind of target adolescent girls. And this is a good learning as well. So how can we work closely with the reproductive health group to catch these survivors? Then also working with protection on access to justice and birth registration and ensuring that the survivors have access to justice. And then finally, working closely with child protection to ensure services for pregnant adolescent girls, but also looking at for the alternative child placement in adoption, fostering, and supporting as well. So having close coordination is needed. This is something that all of the different sectors need to be involved. Okay, next slide. So I'm not going to go through these, but if you can just flip through them. Here are the key resources that we identified. As you can see, there's a lot in the context analysis. The next one, looking at medical care, a number of documents. The next one, please. And also looking at supporting children born of rape and supporting access to justice. Okay, last one slide. And that's it. Any questions?
One question from Claire Hollowell.
Hello, that was so interesting. Thank you very much. I work with IPPF, but I'm still very new, so lots for me to think about here. I had a question around challenges there might be, this might be a bit out of scope, but challenges there might be between supporting a survivor herself and supporting the child. So I know a lot of work generally will focus around child protection and the well-being of a newborn child, with the assumption that the goal is to keep the child with the mother as much as possible. And perhaps earlier approaches didn't necessarily consider the survivor, the mother, as somebody whose needs could be paramount. Are you discovering tensions between a child protection approach and a GBV approach? And if so, what advice might you have?
Yeah, I would agree that there is some tension in that, and that's kind of evidenced in the literature as well. That there's actually much more literature on supporting the child who's born rape than about the survivor herself, and looking through what the options are for the survivor or how the survivor can be supported. And I think that's where coordination comes in really carefully, and using the case management approach, right? So helping the survivor to make the best decision for herself. And also, and I don't know if anyone else wants to, because I talked to a number of you guys about this while writing it, but also just creating a safe place for the survivor, particularly maybe after birth, to think through her options and decide. Because while, before the child is born, there may be a desire, no, I want to get away from this. And then they may wish to actually keep their child, or they may change their mind as well. So how can we have a really, supportive and compassionate response to this person who's been through this? To be able to help them make the best choice for themselves and their child as well. Because we know from what happened in Rwanda, there was some very interesting work there. What happened to these children, that they're all like 20, 22, 23 now, and their lives are very hard because they were always stigmatized as a child of rape, and many of them were not wanted by their mothers at all, and they really suffered from it. So forcing the mother to keep the child when she doesn't want to is not very helpful for the mother or the child either. So Fiona has a nice comment. I don't know, Jennifer, how you want to mention it? Or
yeah, I'm actually worried about time because we're supposed to have a half an hour for Kasi, but I feel like this is a good segue because Kasi is exactly about the coordination between GBV and child protection actors, and they might be able to address some of the challenges that you're sort of mentioning now where there's different opinions. But I'd also encourage you, if you have additional questions, I know Sarah would be delighted for you to take them to the community of practice and have not just asking Sarah the questions, but hearing from each other in response to your questions. So
yeah, because many of you were involved in answering my questions and you're on this call. So I don't want to pretend like I know all this myself. It came from the community as always. Thank you, Jennifer.
Great, so thank you so much, Sarah. And thank you for your question, Claire. And Claire, as she mentioned, she's our new core member from IPPF. So it's great to see her participating, and you might know her from other jobs in the past. So we're glad to see her back with the GBV AoR crowd community, the GBV community. So if we can change over now to Kasi, and we have Vivian, Karina, and Jennifer Lee, and you can see already on this first slide that this is a collaboration between the Child Protection and GBV AoRs, IRC, and NORCAP. And I will not take up any more time. And Karina lit up her photo, so I'll turn it over to Karina. I'm not sure what order you're speaking in, so I'll just hand it over to you.
Thank you so much. I'm gonna swiftly hand over to Vivian.
Thank you so much, Karina, and thanks, Jennifer, for the brief introduction about Kasi. This is how we are going to facilitate the Kasi piece of work. I will be co-facilitating with Karina Hickling, the Kasi coordination piece, and then our colleagues from IRC will be facilitating on the Kasi learning program part of it. So on the Kasi coordination, actually, we are actually working closely with Karina Hickling in terms of providing in-country support. But just to give some background about what Kasi is for those who haven't interacted with us previously. So Kasi is a child and adolescent survivor initiative that was started in 2018. And it's a partnership between IRC, NORCAP, CPAOR, and GBV AoR. At this point, we are in the second phase of the initiative. So the objective of Kasi is to ensure that all child and adolescent survivors of sexual violence, and I'm underlining including GBV in humanitarian settings, have access to quality services that meet their diverse and specific needs. And when we talk about why CASI is there, actually is to bridge the gap between CP and GBV in terms of providing support to all child and adolescent survivors of sexual violence, because I think this is something that has come out more often when we meet with different coordination groups in different countries, saying that sometimes they have a feeling like the cases of sexual violence against children and adolescents should be the responsibility of child protection. And sometimes the GBV actors, the CP actors are saying because it is sexual violence and GBV, then it should be GBV actors addressing those cases. So in this case, CASI, we are trying to say it is the responsibility of both sectors to look at the needs of this group of children and be able to address them more specifically. The next slide, please, Shiva. So what is the CASI approach to coordination? CASI approach to coordination is to strengthen in-country coordination and collaboration between CP and GBV coordination groups or subclusters to ensure that the needs of child and adolescent survivors are acknowledged across the sectors, that is between CP and GBV. Field coordination mechanism, either at the national or the level, or even at the global level, or even within the technical working groups or within the technical working groups in different countries, and also in the HNO and HRP processes. So for the HNO and HRP, we make sure that we do support country coordinators to ensure that the needs of this target group of children are highlighted or included in the HNO and HRP process. Next slide, please, Shiva. So how do we strengthen coordination more specifically? Is we support to ensure that there is, when it comes to GBV and child protection service mapping and referral pathways, there is some inclusion of services for child and adolescent survivors. For example, I think where we've been able to support more closely is Nigeria, where through the CASI learning program application documents, they highlighted that there was need to support more to ensure that their service mapping tools and the referral pathways are updated to include services for child and adolescent survivors. So this is something that we've supported the coordination mechanism to ensure that the service gaps for child and adolescent survivors are addressed, and also any duplication avoided between the two sectors. So we've also supported the development of standard operating procedures. Actually, it should not be the development, the review of the existing standard operating procedures, because for CASI, we do not want to create different or parallel tools or coordination tools, but instead make sure that the existing ones between CP and GBV have child and adolescent survivor issues included or coordination support included in them, and also making sure that they address specific considerations for child and adolescent survivors. So for this one, we've been able to support South Sudan, and we started conversations with South Sudan on this last year. Of course, the point where we reached at was to do a kind of remote workshop for participants, actually the field-based participants who are implementing the standard operating procedures directly in the field. But unfortunately, we could not manage to do the workshop together to go through their specific standard operating procedures because of the remote working, and also the fact that most of the areas are quite remote and there is no access to internet. But this is something that is still on in the pipeline for us to implement for South Sudan. Next slide. Yeah. Something else that we've been able to support on is developing guidance note for case coordination. This is actually a tool that was developed to support effective coordination of support to child and adolescent survivors in locations where both GBV and CP actors existed. So when we say local service agreement, this is not actually a standard definition, but just a name that we gave to that kind of a guidance document that was created for Iraq then. So the document was actually meant to facilitate effective coordination between child protection and GBV actors who are operating in a context where, for example, in a location where both CP and GBV are, there was this kind of confusion on who should take up the responsibility of providing case management and what other additional GBV services could be provided to this group of children. So in this case, we were looking at child protection taking up the responsibility. Of course, it was kind of a consensus building or consistent reaching an agreement, because GBV were kind of child protection should take up the responsibility of providing case management, but if there is any additional GBV service that needs to be provided to those specific cases, then referral should be made to GBV actors in that specific location. Something else, and I think this is something that I had talked previously, is supporting of the HRP and HNO to the coordination groups to ensure that the needs of child and adolescent survivors are reflected in the HRP, HNO. So this is something that also we followed up quite closely with some countries last year, but of course we understand the challenges that we had, the short turnaround, and also the fact that we had limited, we were limited in terms of wording to put into those documents. Next slide, please, Shiva. Something else that CASI coordination has supported on is the development of tools and materials to support CP and GBV coordination group. And I think this is something that I think most of us might have come in contact with last year during COVID-19, where we developed a tip sheet for field cooperation during COVID-19 and beyond. And the aim of this document was is to inspire the GBV and CP coordination group to work closely together, coordinate support to child and adolescent survivors of sexual violence, including GBV. And if you had a chance, and for those who haven't, you can share this after this, or in the chat box after this presentation. This is actually a document that we aligned to the humanitarian program cycle. And we were looking into encouraging the CP and GBV actors to share priorities and develop inclusive working relationship throughout the cycle. I think next slide, please, Shiva. I think this is another document that is in the process of development. And I think I can hand over to Karina to talk about the field cooperation framework and other updates from CASI coordination work. Welcome, Karina.
Thank you so much, Vivian. Jennifer Che, so just looking at the time, and are we finishing on the dot, or how are we able to maneuver this as we have a second part to the presentation?
Yeah, sorry about that. We thought we had extra time and then we didn't. So as close as on the dot as we can, I can, whoever is able to stay can. I know some people have another call right after, so whoever needs to jump off will jump off, and then whoever can stay on a little bit longer can stay on a little bit longer.
And there is a recording of this, so if you're jumping off, then you will still be able to catch up.
Provided.
Okay, good. So let me then continue with the field cooperation framework. So keeping with what I think is the theme for this webinar is around coordination and the need for both CP and GBV, coordination on the ground, as well as also including other sectors and actors on the ground. The field cooperation framework is something that has been discussed for some time, and there is clearly an agreement that there is need for something that supports coordinators on the ground to increase the cooperation. So the objective for the Field Cooperation Framework, the FCF, is to address service provision gaps and avoid if there are any duplication for shared priority populations. And this means that it's a contextualized need for cooperation. It's not a prescribed need, so it's based on what is the on the ground needs. The primary audience for the Field Cooperation Framework are the coordinators and co-coordinators of GBV and child protection subclusters and coordination groups. So we are clearly supporting and targeting the coordination mechanisms on the ground. The secondary audience are the conveners of technical working groups, members of the CP and GBV subclusters, IMOs, global field support functions, for example, the REGAS or the Rapid Response Team in child protection, the child protection and GBV help desks and standby partners. The coordinators have spoken. They have told us that they want practical support for addressing functional areas of cooperation. So this is the Field Cooperation Framework is aligned to the 6+1 coordination functions as established by IASC. So the reference model for cluster coordination at country level. Next slide, please. So why do we need this? I'll just give a little bit of a background. So we know that CP and GBV actors, as we've heard this evening, have overlapping responsibilities for response and prevention of GBV, including sexual violence affecting child and adolescent survivors of sexual violence, and also other perhaps priority populations that you have shared responsibilities for. And there is a need to cooperate to generate better knowledge and develop skills and more resources, and the cross-sector coordination and cooperation with areas for health, MHPSS, etc. There are new and growing needs, and we know it affects both boys and girls. We also know that we need to support the leadership and implementation of diversified local and youth-headed organizations and local actors. So this is clearly part of the reasons for why we are developing this. We also have a clear understanding that there is a need to facilitate the practical cooperation between these diverse actors to ensure that there are service provision and that the gaps are addressed in a proactive way. So the GBV and Child Protection Field Cooperation Framework relates to everyday practice, and it's the hope that this will be a reference for cooperation between the subclusters so that we achieve better outcomes for children and adolescents and other shared priority populations. We ensure through this that the framework supports maintaining specificity in responsibilities and mandates to generate synergies through increasing communication and identifying areas for collaboration. This means that we definitely build on each sector's or subcluster's technical expertise in order that we become better together and that we don't have child and adolescents falling between those responsibilities. So the idea is that the GBV and Child Protection Framework apply to each of the core functions, and that it includes clear recommendations for cooperation, and that we also include practical examples. How is this done? Because it is done, and it's done in very good and inspiring ways, and that we need to share those with our peers as coordinators. So providing those tips, highlighting promising practice will be part of the field cooperation framework. Next slide, please. So did we jump a slide? Sorry, could you go back? So the GBV and coordinators is at the center of this, and we really would like to ensure that the coordinators are part of the whole development process. So we have had initial consultations with coordinators and co-coordinators in regional consultations. We have also undertaken consultations with RRTs, the RIGAs, and invited the GBV and CP AoR teams. And we are in the process of consolidating that, and we'll take this consolidated field cooperation framework for input from the AoR. So the key stakeholders that the both AoRs are interacting with. This we will then take back to the coordinators, because we would like to ensure that the coordinators on the ground have ownership of this, and we are growing the field cooperation framework from bottom up. So having them involved in the final sign-off is important. We will then have an opportunity to showcase the promising practices in regional workshops and webinars to also launch the field cooperation framework. And it will be the basis of a training and workshop package that can be used by the global and regional support functions to in turn support the coordinators on the ground. We're also looking at how we include cooperation with health, MH, PSS, SRH, education, camp management and coordination, etc. Because as has been highlighted several times in this webinar, is that the need for cooperation doesn't necessarily stop with CP and GBV, and needs to address the priority populations outside of these two. Next slide, please. We're also working on a participatory barrier analysis, which is an attempt at working directly with child and adolescent child and adolescents to understand better the what are the barriers to services, and this is happening in 2 pilot countries at the moment, Kenya and the Philippines. What this means is that we are looking at how to, in a involving young people from the very beginning of actually formulating the questions. What do we need? How do we approach the issues around access? How do they see that the access issues that their peers are affecting their choices? And leading from there, undertake data gathering in whatever form that might be. That can be focus group discussions, which is at the moment quite a challenging setup because of the COVID restrictions and the moving COVID restrictions. How do we do this? So we're working around those and trying different ways of engaging young people. We know, of course, that young people have more access to internet-based platforms where they spend a lot of time. However, that, of course, may exclude some particularly vulnerable groups. So ensuring that we are reaching out and understand better how adolescents see the access barriers affecting them. From there, from having gathered the data, and the core group of young people will be involved in analyzing the data and also come up with priority actions to address this, and something that they will be part in implementing. So this is a methodological development. How do we meaningfully engage young people, not just visiting them to ask them questions and then take the answers away and go and develop their programming for them. This is with adolescents to take charge of some of this themselves and be engaged in addressing it. We're also hoping that this will be able to be communicated to other young people as we go, not just to us adults and donors, but it's actually something that young people can speak to other young people about. And then, of course, part of what we're working on in CASI is to expand on the collaboration with other sectors. And this is something that is ongoing, and we're looking at engaging at different levels, preferably, or at the moment, this is mainly happening at national level. And then as another part of CASI is documentation and sharing of promising practices and lessons learned. Next slide, please. So we are available, so Vivian and myself are available to support coordination on the ground. So if you feel that you have a small or a big issue or concern or suggestions around coordination, please reach out to us. And we can start informally just through an email, or you're welcome to contact us on Skype, and we will guide you through the process of if this request is developing into a more formal request. But we are there to help out and support things like another pair of eyes on the SOPs that you're developing. Is it covering and adequately addressing both child and adolescent survivors, as well as is it working for GBV and CP actors? And we're happy to be a reference point when you're looking at developing your referral pathways, etc. So do reach out, we're here, and it can be a very informal approach. Okay, thank you. Next slide.
So I have a proposal, because we have IRC still presenting, right?
Yes.
So I'm just wondering, because we still have 43 people online, but we've had about 25 jump off. And it's kind of a natural break. And I'm wondering if you would be interested in presenting from IRC, which is kind of a slightly different section anyway, if we present on the next call, which would be next month. And then we'd have time for more discussion and questions and answers. What do you think? Sarah Mosley is saying it makes sense to her. And we're actually, yeah, I don't know. I mean, you could start with a quick sort of summary and then go into the IRC, but I'll leave it up to you guys.
What do you feel like, Tisita?
I think that would be fine, because it's, there could be questions and comments. So we appreciate for giving us the other opportunity.
Yeah, I'm sorry, because I thought we had all this extra time since Mendy couldn't come, but what we could do is send out maybe a slide or two of a summary from the first half to people in anticipation of the call. And then maybe just have like a quick, refresher, and then have IRC present, and then have time for a real discussion, if that works for everyone.
Thank you.
Yeah. Could we, if there are any direct questions now of the people that are still here, we are happy to address those, of course.
Okay, so are there any questions for Vivian and Karina based on what they just presented? I'm trying to see if there's any hands. Shiva, are you seeing any hands that I'm not seeing?
No, and I don't see anything in the chat either. Sorry, it's Astrid.
Okay, so I think that we can still have questions also to you both in the next call, and it might be because the people are getting ready to get off. And Pamela has a quick announcement about her presentation coming up on the 4th. So if you're okay, Karina and Vivian, also people can send us questions, and I see there's other people who are trying to jump off as well. So let's organize it. We can discuss before the next call so that there's an opportunity to recap. And then I'm just gonna ask very quickly, Pamela, 1 minute, if you can announce your presentation that's coming up on HNPW.
Thanks, Jennifer. There's actually a query from Catherine in the chat box on how will the core members engage with the review and sign off. So just to flag that it's there. So the GBV AoR is organizing a session within the HNPW on how climate change fuels gender-based violence. And we are aligning this technical session vis-a-vis the priority topic on anticipatory action initiatives and partnerships, which have gained significant momentum within the humanitarian sector in recent years. So it will focus on GBV early warning indicators and effective anticipatory action intervention models in relation to gender-based violence. As of today, we have about 400 registered participants. And it's interesting that we'll have a mixed audience. In addition to GBV actors, we have climate change specialists, DRR technical advisors, early warning, AA specialists, and forecast-based financing experts. So this can be an opportunity for networking and connecting with regional and country level actors that are working on climate change and specifically on anticipatory action approaches. So we hope to see you there. Thanks, Jennifer.
Thank you, Pamela. And Catherine Poulton, we have noted your question and we will include that in the next call so that we can respond in that call. And we'll see if there's any other questions in the chat, but I feel like that's a longer response. So, so thank you everyone for joining. And I feel like we had a really rich conversation today. It was great to see more participation. So I think that's a lesson learned for me to know that it's good to have fewer presentations so that we can have more discussion now that people are being more active. And also, I also really liked having a presentation on the Helpdesk article. So thank you, Sarah Martin. And that might be something we can do more of in the future because there's always very interesting papers coming out of the Helpdesk, and Pamela's presentation for the HNPW is also presenting a document that's been written for the Helpdesk. So that's another opportunity. So thank you all and have a nice rest of your afternoon.